Oh, no, I guess.
And do to your computer if you did.
Yep.
Sweet. Yep, it's working. So whenever you're ready, you can start.
Okay. All right. Hi, my name is Duncan. I'm a student intern, and our patient Robert Decker is presenting with a chief complaint of his heart racing. And to give you some background on the patient, he's a 55-year-old white male presenting with symptoms of heart racing, palpitations, dizziness, lightheadedness, anxiety, chest tightness, stress, and fatigue. He doesn't have any chest pain or radiation of that chest tightness. The heart racing has been something that has been happening for the past 10 to 14 days on and off. And the patient states that sometimes it's a result of physical activity, but it also happens at rest sometimes as well. The chest tightness is a new symptom as of today and started just before coming into the ER. And the patient has never had a mechanical heart valve placed, no history of COPD, and no heart failure, and no previous history of atrial fibrillation. The medical history for this patient is that he has hypertension, hyperlipidemia, diabetes, and obesity. His current medications that he is on is the irbesartan 150 milligram daily, atorvastatin 40 milligram daily, semaglutide 1 milligram weekly, and a multivitamin every day. He was also prescribed a hydrochlorothiazide in the past, but states that he doesn't take that because it makes him urinate too frequently. Um, the patient's dad died as a result of a myocardial infarction, and his mom has hypertension, and his brother has hyperlipidemia and has also had a heart attack. The patient is also a current smoker, but is not interested in quitting, and he states that he drinks 6 to 7 drinks every week, um, and he doesn't report any illicit drug use or caffeine consumption. His vitals include a blood pressure of 150 over 82, a heart rate of 153, a temperature of 37.6 degrees Celsius, respiratory rate of 20, and O2 sats of 92% on room air. His EKG shows AFib with rapid ventricular rate, and his labs that were performed include serum creatinine of 1.12, a BUN of 24, a potassium of 3.6, and a magnesium of 1.8, as well as a troponin of 0.01. His calculated CHADS VAS score is a 2 based on him having hypertension and diabetes history. His physical exam showed irregular pulse and no other abnormal findings on the physical exam. Um, where the patient is an older male with a history of hypertension, hyperlipidemia, diabetes, and obesity, that puts him at risk for a range of cardiovascular diseases. So, the heart racing, palpitations, dizziness, lightheadedness, anxiety, chest tightness, stress, and fatigue are all characteristic signs of atrial fibrillation. A lot of these could also be a characteristic of anxiety or low blood pressure. The low blood pressure can immediately be ruled out since the patient has a blood pressure of 150 over 83. The anxiety being the cause can also be ruled out based on the EKG showing the AFib with rapid ventricular rate. The chest tightness that he was experiencing indicates that he could possibly be having a heart attack, but where his troponin level is so low and there's no radiating symptoms or chest pain, an MI is unlikely to be the cause. And other arrhythmias can be ruled out as well based on that EKG finding. And so this leads us to our diagnosis of new onset atrial fibrillation with rapid ventricular rate. One short-term goal for this patient is to achieve a heart rate of under 110 at rest and when physically active. Um, a long-term goal for this patient is to work with the primary care provider to get his blood pressure under 130 over 80 after being discharged. Another long-term goal for the patient is to prevent them from having a stroke when leaving the hospital. And another goal for the patient is to resolve their symptoms in the next 24 hours. The AHA-ACC 2023 guidelines recommend rate control as the first line therapy. There's 4 classes of medications that can be used first line. Um, these are beta blockers, non-DHP calcium channel blockers, digoxin or amiodarone. Since the patient doesn't have a history of heart failure, the beta blocker or the calcium channel blocker is preferred. We don't want to use the digoxin or the amiodarone. And an article in the BMJ journal titled Rate Control and Atrial Fibrillation, Calcium Channel Blockers versus Beta Blockers compared the use of beta blocker therapy and calcium channel blocker therapy. The study was mostly older white males with an onset of AFib. In the study, beta blockers had an average heart rate of 66, and those on non-dihydropyridine calcium channel blockers had an average rate of 69. So these results were given with a p-value of 0.001. So it's safe to say that this applies to our patient. And based on this, a beta blocker should be used because it's better at rate control based on that study. Specifically, a cardioselective beta blocker, bisoprolol is a good option because it's a cardioselective beta blocker and it's only taken once a day as an oral medication. The guidelines didn't state any preference for IV beta blocker therapy, and it's also a very cost-effective medication. And then since the patient has a CHA2DS2-VASc score of 2, the AHA-ACC 2021 guidelines for stroke prevention, anticoagulant therapy is recommended. Since it is for the prevention of stroke related to AFib, DOAC is recommended as the first line. Since he has no history of a mechanical valve, warfarin is not recommended. So rivaroxaban is what I recommend as a once daily medication because it has good efficacy data in atrial fibrillation. And then my recommendation is to start the patient on bisoprolol 5 milligrams, 1 tablet by mouth daily, can be titrated up to 20 milligrams daily to achieve a goal heart rate. And then Xarelto 20 milligram tablet once daily every evening with a meal. The patient should also be referred to cardiology to assess the need for cardioversion. He should also be seen by his PCP in 1 week from discharge to assess vitals, blood pressure, EKG, and those symptoms of like the chest tightness, dizziness, lightheadedness, anxiety. And then while in the hospital, his vitals, especially blood pressure and heart rate, should be checked every hour, and ECG should be checked continuously. They should be physically checked and evaluated every hour. At the hourly checkup, symptoms should also be evaluated, and then specifically looking for the symptoms of heart racing, palpitations, dizziness, lightheadedness, anxiety, chest tightness, stress, and fatigue. And then a response check should also be performed daily to assess the need for dosage changes or additional therapy. And then did you have any questions on that, or would you like me, or does that sound good?
Yeah, no questions for me.
Okay.
Yeah, you can go ahead and share that with the provider and their team.
Okay.
Perfect, thank you. All right, you can stop recording.